All right, welcome to the deep dive. Today we're diving into something uh, really fundamental if you want to make informed health decisions, understanding the evidence behind medical treatments.
Yeah, and this is especially important when you're talking about therapies where, the evidence seems a bit debated, like hyperbaric oxygen therapy.
Exactly. So we've pulled together some source material that really unpacks how medical studies work, what makes some evidence stronger than others, and importantly, how you can navigate it all.
That's the goal. We want to help you understand what good evidence looks like, particularly from well-designed studies, and how you, maybe as a patient or a caregiver, can look at the info out there and feel a bit more confident figuring it out.
We're using hyperbaric oxygen as our case study here because it really highlights a lot of these challenges and nuances.
It does.
So let's jump in. Why are certain studies, these randomized controlled trials, why are they often called the gold standard for figuring out if a treatment actually works?
It really comes down to tackling bias head on.
Bias, right.
Think about it. If a doctor or even a patient really hopes a treatment works and they know who's getting the real deal and who isn't, well, that knowledge can subtly color everything.
How they feel, how the doctor assesses them.
Exactly. How results are recorded even. That's bias just creeping in.
And the source material uses a great image for this. Proper randomization in these trials, it's like letting pure chance, just chance alone, decide who gets which treatment.
Yeah. It takes human influence, like beliefs or preferences, right out of that decision of who goes into which group.
Which is crucial.
Absolutely. And by sorting people just by chance, you also make it way more likely that the groups are similar in pretty much every other way except for the treatment they get.
Okay, so that minimizes the risk that something else is actually causing the difference you see. Some hidden factor.
Precisely. Those hidden factors or confounders. Randomization helps control for those.
Okay, so if those trials are the gold standard, how does other medical evidence stack up? The source talks about this evidence hierarchy, sort of like climbing a ladder. Could you give us the quick tour?
Yeah, think of it like that. The higher up the ladder, the less likely the evidence is skewed by bias. Down at the bottom rung, you've got things like maybe a single story about one person's experience or just an expert's opinion.
Interesting, but maybe not the most reliable on its own.
Valuable, yes, but definitely the most prone to influence and other factors playing a role.
And as you climb the ladder,
you get into study designs with more structure, more control. The source lays out these levels right at the top. That's class 1 evidence. You've got systematic reviews. These combine results from lots of high-quality randomized trials. That's class 1A.
Okay.
And then you have the individual, well-done randomized trials themselves, class 1B.
And below that, still useful stuff, but maybe more potential for bias.
Right, like class 2.
Yeah.
That includes reviews of studies that didn't use randomization, class 2A, and also individual studies that didn't randomize but did have some kind of control group, class 2B.
Okay.
Then there's class 3, studies without randomization but still comparing groups. Harder to be sure the groups were truly similar at the start, though.
Makes sense.
And below that, you get class 4, like case series, just looking at a group who all got the same treatment, no direct comparison group. And finally, class 5, the expert opinions or single case reports we started with. It's just a way to weigh things.
That hierarchy is really helpful. And the source also mentions different types of trials, even within that top tier explanatory versus pragmatic. Why should someone listening care about that difference?
Good question. Explanatory trials are designed to test if a treatment can work under, ideal, very controlled conditions.
In a lab setting, almost.
Sort of, yeah.
Okay.
Whereas pragmatic trials ask if it does work out in the real world, the messy reality of clinical practice with all sorts of patients.
So for me, looking at results, it helps me think, okay, does this study's setup actually reflect my situation?
Exactly. With your other health issues, your daily life challenges, all of that. Does it apply?
Now, doing these gold standard trials, it's not always straightforward, is it? Especially for therapies like hyperbaric oxygen. There's this concept, clinical equipoise.
Yes, clinical equipoise. It's this ethical principle that basically doctors running a trial have to be genuinely unsure which treatment arm, the new one or the standard placebo, is actually better for the patient.
Because if you think one is clearly better, it feels wrong to randomly assign someone to the potentially worse one.
Precisely. And if experts are already really strongly convinced one way or the other, maybe based on their experience, it can lead to this sort of research stalemate. They don't feel they can ethically randomize.
But the source brings up another idea. Behavioral equipoise.
Right. It suggests trials might still be ethical, even if some individuals feel certain, as long as there's genuine controversy or uncertainty within the wider medical community. Maybe because of different experiences or values or even biases.
Sort of like the community hasn't reached consensus, so the question is still open and needs rigorous testing.
Exactly. It acknowledges that disagreement exists for various reasons, and studying it might be the only way forward. The idea that an extraordinary claim often requires extraordinary proof.
Yeah, that makes sense. And this all ties into evidence-based medicine, or EBM, which sometimes gets a bad rap, right? Like it's just cookbook medicine or about cutting costs.
It really isn't either of those things. EBM isn't about rigid rules.
So what is it then?
It's about doctors thoughtfully combining three things. First, the best available research evidence we can find.
Like from that hierarchy we talked about.
Yes. Second, their own hard-won clinical expertise and judgment. And third, crucially, your individual values and preferences as the patient.
Ah, okay. So it's about tailoring the decision to the individual, using all those pieces.
That's it, exactly. Finding the best path for you.
And the source points out, EBM doesn't always mean you need a big randomized trial. Sometimes that's just not feasible.
Right. For really rare conditions, for example, or situations where outcomes are typically terrible and a new treatment seems dramatically effective for almost everyone who gets it.
Like the early days of insulin for diabetes, maybe?
Perhaps, yeah. In cases like that, even well-documented case series, Class 4 evidence, might be the best available guide for practice if randomized data just doesn't exist. It's about using the best evidence you can get.
Okay. So when scientists are designing those good trials, what are some key things for us to look out for?
Well, sample size is a big one. The study needs enough patients to actually have the statistical power to find a meaningful difference, if one truly exists.
So those small pilot studies aren't usually definitive.
Usually not. They're often just preliminary, testing the waters. You also need something called concealed allocation.
Concealed allocation, what's that?
It means the person enrolling patients into the trial, like the doctor signing them up, absolutely cannot know or even guess which group treatment or control the next patient will be assigned to.
So they can't subconsciously steer certain types of patients into one group or the other?
Exactly. It prevents that subtle sorting. And then there's blinding.
Right, keeping people in the dark about who got what.
Ideally, yes. You want to mask who's getting the real treatment versus a sham or placebo treatment. Both the patient and the person assessing their outcomes should ideally be blinded.
Which sounds particularly tricky for hyperbaric oxygen therapy. I mean, how do you fake being in a pressurized chamber?
It is tricky, but the source mentions methods people have tried, like using only minimal pressure or pressurizing briefly, then returning to normal air pressure, or even having people breathe less oxygen, like normal air, but still at full pressure.
Huh. Do those work?
Well, the source notes that blinding has been shown to be successful in some hyperbaric studies. The goal is always to stop expectations, either the patients or the assessors, from messing with the results.
Okay. And how should they analyze the results?
A really important principle is intention to treat analysis.
Intention to treat.
Yeah. It means you analyze patients based on the group they were originally assigned to, right at the start, even if they, say, dropped out or didn't complete the full course of treatment.
Why do that? It seems counterintuitive.
Because it reflects the practical reality of using the therapy. In the real world, people do sometimes stop treatment. Analyzing by intention to treat gives you a better idea of the therapy's effectiveness when offered in a real clinical setting.
Okay, I see. So with all these different studies and complexities, how does someone actually find the evidence, say, for hyperbaric oxygen? Is it scattered all over?
It used to be harder, but it's gotten much better. There are now resources specifically for hyperbaric evidence, like dedicated databases.
Oh, good.
And major groups like the Cochrane collaboration do fantastic work. They produce systematic reviews where they gather and critically assess all the relevant high-quality trials on a specific question and summarize the findings.
And is there much out there for hyperbaric?
Oh, yeah. The source mentioned finding over 400 relevant citations and, get this, over 40 Cochrane reviews specifically related to hyperbaric oxygen therapy.
Wow, over 40 reviews. That's a lot more than I think many people might realize.
It's a substantial body of work, definitely.
Still, you hear about controversies, right? Like that whole debate about finding the right sham control, especially for conditions like, say, post-concussion symptoms.
Absolutely. That's an ongoing discussion. Some argue that any time spent in a pressurized chamber, even just breathing normal air at pressure, might have some kind of physiological effect.
Making it hard to find a truly inactive placebo.
Exactly. So the debate continues about whether, for certain conditions, maybe comparing hyperbaric therapy simply to the usual standard care is actually the most practical and ethical approach, rather than trying to create a perfect sham.
Okay, so bringing it all together. The bottom line seems to be that well-designed randomized controlled trials are really valuable. They're our best tool for minimizing bias and feeling confident that a treatment is actually the cause of any benefit we see.
That's the core idea, yes. And while there are definitely unique challenges in studying therapies like hyperbaric oxygen rigorously, especially around blinding and those ethical questions like equipoise, there is a significant and growing body of evidence out there for people to explore.
Which leaves us with a final thought, really a question for you listening. Knowing about these different levels of evidence, the specific challenges in studying treatments like hyperbaric oxygen, and the debates that exist, how does understanding all this complexity maybe change how you look at medical information or how you discuss treatment options with your doctor? Something to chew on.